Hello, so we're going to talk a bit about the OET speaking criteria. So let's start with a quick look at the exam. Now, taking a quick look at the exam, we've got, especially in the speaking part, we've got 3 minutes for preparation, and then we've got 5 minutes for the actual role play. So that means they're going to give you two cards. Each card is going to have two parts, one for the doctor and one for the patient. The patient, of course, is going to be the interlocutor, the person in front of you. They're going to prepare the patient's part, and you, as a doctor, are going to prepare the doctor's part. So that means you're going to take a quick look at the card and you're going to think, okay, how should I start the card? What questions do I need to ask? What criteria do I need to fulfill? So for 5 minutes, you're going to be highlighting your skills and showing people that you have the skills that they're looking for. Um, so first of all, they're going to give you the card. They're going to give you 3 minutes for preparation. And then when they start the role play, they're going to start a 5 minute timer. And you're going to talk to the person in front of you for 5 minutes, which are going to be recorded. And then the record is going to be sent to somebody with a checklist. That checklist is the criteria list. They're going to listen to what you're saying. And then they're going to say, okay, he did this, he didn't do that, he did this very well, he did that not so well. And then they're going to grade your score. They're going to grade your performance, and they're going to give you a score. That should be done by two people, not just one person. And then you get the score, I guess the average or the score that they both think you deserve. So generally speaking, the person in front of you is just a role player. They're just helping you to like run the scenario, or run the card, or uh, you know, act as if there was a real patient in front of you. Then the person grading you won't even be in the room. They're just going to be listening to the record. So that means you need to depend on your verbal skills rather than your actual communication skills, because we know that there's eye contact and keeping a smile on your face and all of that. It doesn't really show in the record. So what does show in the record is each and everything that you say. So you need to focus on that. Now, when the two people in the room, you and the interlocutor, finish doing the role play and the record is sent, what are the criteria that are going to be used to grade you or to give you a score? Let's see. So these are the OET speaking criteria. Um, Generally speaking, we've got two groups: linguistic criteria and communication criteria. As you can see on the screen, the linguistic criteria are intelligibility, fluency, appropriateness of language, resources of grammar and expression. And the communication criteria would be relationship building. After that, there's understanding and incorporating the patient's perspective, followed by providing structure, information gathering, and finally, information giving. Now, they don't have to be in that order, but have to keep in mind that those are all main criteria, and under each one of those criteria, under each criterion, there's a set of sub-criteria. So when we say intelligibility, for example, that means how well they can understand what you're saying, because it's clearly pronounced, it's clearly stated. They're not facing any difficulty in making out which words you're trying to say, or you know, figuring out what you're trying to deliver. Then you've got the fluency part, which means not how fast, but how smoothly you're speaking. So that means you're speaking without hesitation, without interruption, without having to stop in the middle to think or make up a sentence or whatever. So that means you're fluent. Also, how well and how fast you can come up with a response, and how well and how fast you can ask a proper question, stuff like that. So generally speaking, it's about how smooth words flow out of your mouth. Then you've got appropriateness of language, which means as a doctor, you're speaking to a patient in a professional way because you're a doctor. And at the same time, you're using simple language because that patient isn't a doctor. He's not in the medical field. He or she isn't in the medical field, so they can't really understand any medical jargon. So you need to simplify everything to the level of the lay person, or the person who doesn't know anything about medicine, because that's what you'd expect from a patient. If they have any information, that's fine. You can build on that. But you have to start with the assumption that they know nothing about the subject and they know nothing about medicine. So you have to simplify everything and avoid medical jargon and avoid any inappropriate language or any, over-friendly way of speaking, any casual way of speaking. You need to be professional and at the same time simple. Finally, you've got resources of grammar and expression. So that means at the very least, you can use the simple tenses, past, present, and future. So you can mix things up. You can ask questions. You can tell the difference between a question and a sentence. You can ask a proper question. You can ask questions using different ways, whether it's an open question or a closed question. You can express yourself clearly because sometimes you can ask the same question in different ways. Each one of them has a different meaning. So you need to know how to express yourself and ask questions and run the conversation using various expressions, including idioms, by the way. So idioms are expressions that you can use which don't have the exact meaning that's written or that's pronounced. It has another meaning. So, for example, when it's I don't know, like a really famous idiom would be "It's raining cats and dogs." So it doesn't mean that there are cats and dogs coming down from the sky. It means that it's raining heavily. Yeah. So you can use any expressions like, in a nutshell, I'll tell you what's going on. Well, it's a bitter pill to swallow. It's better safe than sorry. Stuff like that. They add to your score. Now that we've talked about the linguistic criteria, which are intelligibility, fluency, appropriateness of language, and finally, resources of grammar and expression, let's move on to communication criteria. Now, clinical communication is evaluated by looking at these 5 points. Number one, relationship building. So that means if you know the patient, you make it clear that you know them. So you welcome them for the second time. You use their name, if you know it. You start by asking about their name, by establishing any kind of connection. You start the interaction. You don't wait for the patient to start it. You take the lead and you start it. You show empathy towards anything that the patient's saying. You listen well to the patient. You make it clear that you're listening and that you're still there and that you're attentive by asking follow-up questions and by showing listening sounds. So you make some listening sounds to tell the patient that you're still there and you're listening and you'd like them to continue speaking. So you don't make, oh, okay, just go on. It's not like that. It's more like, okay, I'm there, I'm listening, like that. After relationship building, you've got understanding and incorporating the patient's perspective. Now, if you remember when we talked about appropriateness of language, we said sometimes the patient knows nothing about the subject. Other times, the patient has some information or some knowledge of the subject. So to know that, you need to ask the patient. When you ask the patient, so how familiar are you with this subject? How much do you know about that disease? Like that, patient tells you they know some stuff, or they know nothing, or they've heard the term, but they don't fully understand it, whatever you want to say. So you start from there, and then you build up. So if the patient has a bad experience with a certain kind of treatment, you don't just keep telling the patient about the benefits of the treatment. No. You have to start from where the patient is. So the patient tells you they have a bad experience. You tell them, okay, I'm really sorry to hear that. I know that it sounds like it's a dangerous kind of treatment and it can have some life-threatening potential. However, let me tell you that since the time that your aunt died, there's been a lot of progress in medicine, and that there's been a lot of progress in medicine, and that the current devices have a much higher rate of success and a much lower risk. And we're not going to force you to do anything. It's totally up to you. So let me just walk you through it, and then you can decide for yourself. After understanding and incorporating the patient's perspective, which means you start from where the patient is, and then you build up from there. You don't just speak your mind without thinking about what the patient knows or doesn't know. The third point would be providing structure. So that means starting from the beginning, you tell the patient what you're going to do during the consultation or during the visit. After that, you make the transition clear using something called signposting. So at the beginning of each part or each segment, you let the patient know that we've finished something and we're going to start something else. You let the patient know that we're doing something else. So we tell them, now I'm gonna ask you some questions about what happened. Let's discuss the treatment options. Okay, let's get deeper into the surgical options that you have, and we're gonna start to decide which one is the best for you in this case. After that, after providing structure, after signposting, I mean, you can also provide structure by numbering the items that you have. So you can tell the patient, now the risk factors in this case are 1, 2, 3, 4, 5. So you number them so that he knows that there's a list. Or you can divide them into groups. You tell them the treatment options we have are divided into 2 groups. You've got the lifestyle changes that you need to make, and then you've got medications that we can use. So the first thing is the lifestyle changes. They include 1, 2, 3. The medications we can use include this, and that. So you can group the items, you can number them, you can use signposting, you can make the transition clear, you can let the patient know exactly what you're going to do during the consultation. All of that is considered providing structure. Another point is information gathering and then information giving. So information gathering means that you have to know exactly what you're dealing with. That includes history taking. It includes a lot of things during the card. It includes clarifying anything that might not be clear. Any source of confusion should also be clarified using information gathering techniques. But the general idea is that you have to ask different kinds of questions, starting with an open question. You let the patient answer that question, and then you start asking follow-up questions, which are generally more specific and more closed. You start with the general question, you end up with a specific question. You start with an open question, you end up with a closed question. So there's a logical sequence, starting with the general, more open questions, ending with the specific, more closed questions. Of course, you avoid leading questions, which means questions that don't really give the patient a chance to speak. They shove an answer into the patient's mouth. So you need to avoid those. So you're feeling uncomfortable, aren't you? You're here because you need some medicine, don't you? You're here because like that. So don't ask that kind of question, and don't ask a complicated question that the patient doesn't understand, or a compound question the patient might not answer in a clear way. So don't ask the patient, so do you have diarrhea or constipation or feel nausea or have a headache? So if the patient says yes, what does that even mean? So he's saying yes to all of them, to some of them, to the first one, to the last one, to the third one. What does it mean if he says yes or no? It means nothing. It's really confusing for you. And if you build your diagnosis on that yes or that no, then you're going to have a misdiagnosis, and there's going to be a bit of a problem for the patient. So it's far better to just ask each point separately, ask each question separately, and inquire about each point in a clear way that doesn't leave room for misunderstanding. So you avoid leading questions, you avoid compound questions, you avoid confusing questions, you avoid personal questions, you ask open questions followed by closed questions. That's the general idea of information gathering. Finally, you've got information giving, which means you give the information to the patient, the information that he needs, which means you're going to answer his questions, you're going to explain things to him, you're going to discuss things with him, you're going to give information in a clear, concise way, you're going to give information in chunks. So you're not going to keep talking for 20 minutes. No, you're simply going to start giving the patient some of the information and then checking his understanding. You're going to give him some suggestions and then check how willing he is to cooperate with you or to listen to you. So you've got, you chunk and then you check. So you divide the information that you're trying to give into suitable or appropriate chunks, which means it's long enough to have some content, but it's not too long in a way that confuses the patient. And after each chunk, so if you're explaining a disease, for example, you can start by defining the disease and mentioning the causes of that disease. And then you check. So before I proceed, is it clear so far? Yeah, it's clear. Okay. Now let me tell you about the ways we prevent that disease. We prevent it by doing this and this and that. And the treatment options we have, I'll tell you in a minute, but do you have any questions? No, I don't. Okay. So now the treatment options are, we've got this group and that group. This group includes 1, 2, 3. That group includes 4, 5, 6. So how does that sound to you? Are you willing to try this medication? Well, I don't get it. What does that medication do? Okay, let me explain to you. And then, so there's like a conversation. It's not you talking and it's not a monologue. It's more like a dialogue. You explain things to the patient. You give the patient a chance to express his mind, because when you explain the treatment options, for example, he might tell you, well, okay, I've heard that option before and it killed one of my relatives. I've heard that option before and it didn't really help my friend. I've heard that option before and it worked miracles for a friend of mine. So I really want to try that. So you need to give the patient a chance to express themselves. So that's information giving. You give the information in a clear way, in a concise way, avoiding medical jargon, avoiding any kind of confusing structure, speaking for an appropriate length of time, giving the patient and pausing periodically, giving the patient a chance to express themselves and to also ask for clarification if they need it. So that's checking understanding. The general concept is chunking and checking. And it also has to be given in an organized way, so that makes information giving and providing structure a bit intertwined. They go hand in hand. And once you're done with all of that, you kind of check if the patient needs any clarification, if everything's clear. You agree on what's going to happen next, and that's it. The card's done. You make it clear that the card's done. So thank you so much for coming to see me. I'll see you in a couple of weeks or whatever you want to say. And then you end the card with a smile and you get a really good score.